The central concept for this entire talk. Anaerobic bacteria don't choose to live in wounds, abscesses, and necrotic tissue because they're particularly aggressive. They live there because that's where the oxygen isn't. And in veterinary medicine, we create those environments all the time through bite wounds that seal over, through gut perforations, through devitalized tissue after trauma, through retained placentas. Once you understand what makes a microenvironment hospitable for anaerobes, you'll recognize anaerobic infections before the culture results are back. Most bacteria we talk about in veterinary medicine are facultative anaerobes. They're flexible. E. coli will grow perfectly happily whether oxygen is present or not. Obligate anaerobes are different. Oxygen is genuinely toxic to them. They lack the enzymes catalase superoxide dismutase that neutralize the reactive oxygen species produced in an aerobic environment. Expose them to air, and they die. This is why anaerobes almost never establish infections in healthy, well-perfused tissue. They need ischemia, necrosis, a foreign body, or a deep sealed wound to create the low oxygen microenvironment where they can thrive. The clinical implication. Whenever you see a wound that's deeply invasive, smells putrid, or produces gas, think anaerobes. The paradox of anaerobic disease. The organisms that cause it are almost always already in or on the animal. They're normal residents of the gut, the mouth, and the reproductive tract. They cause disease when they get somewhere they don't belong or when the local tissue environment shifts in their favor. A dog that aspirates after anesthesia, stomach contents enter the lung, the anaerobes from the oral cavity and stomach go with them, and the resulting aspiration pneumonia has a significant anaerobic component. A mare with a retained placenta, the uterus becomes hypoxic and contaminated, and the normal vaginal anaerobes bloom into a severe metritis. It's not exotic organisms causing these diseases. It's your patient's own flora in the wrong place. The Clostridia we've covered in prior talks, but I want to draw your attention to Fusobacterium necrophorum, which deserves more attention than it typically gets in curriculum. It's one of the most economically important anaerobic pathogens in large animal practice. It causes foot rot in cattle, the interdigital dermatitis and necrosis that causes severe lameness in dairies and beef herds. In feedlots, it causes liver abscesses. Animals consuming high concentrate diets develop ruminitis from acidosis. The rumen wall is damaged, and Fusobacterium from the rumen contents gains access to the portal circulation. In calves, it causes necrotic laryngitis, calf diphtheria, one organism, three major diseases in cattle, all driven by the same principle. Damaged tissue, anaerobic microenvironment, Fusobacterium blooms. The biggest mistake clinicians make with anaerobic infections is not thinking of them. By the time culture results come back, if the sample was even collected correctly, you may have already missed the window for optimal treatment. So learn to read the clinical signs. That sweet putrid smell from an abscess? That's short-chain fatty acids and hydrogen sulfide, metabolic byproducts of anaerobic fermentation. Crepitus in a wound, that crackling sensation under your fingers, means gas is being produced in the tissue. That's a hallmark of clostridial myonecrosis or emphysematous infection. No routine culture growth despite clear infection on cytology. Think anaerobes. They died on the way to the lab if the sample wasn't transported properly. These are organisms that reward clinical pattern recognition. Pharmacology here is elegant and clinically important. Aminoglycosides, gentamicin, amikacin, are completely inactive against anaerobes, not because of resistance mechanisms, but because the drug's uptake into the bacterial cell requires an active oxygen-dependent electron transport chain. In an anaerobic environment, that transport is absent. You're not fighting resistance, you're fighting physics. By contrast, metronidazole is actually activated by the anaerobic environment. The anaerobe's own fermentation enzymes reduce the drug to a toxic radical that damages DNA. It's brilliantly targeted. And never underestimate the surgery. You can give perfect antibiotic coverage, but if you haven't drained the abscess, debrided the necrotic tissue, and opened up the wound to oxygen, you've left the anaerobic microenvironment intact. The bacteria will persist. The core message of this talk is about the microenvironment. The organisms aren't the starting point. The conditions are. When you see a patient with a deep wound, a gut perforation, an aspiration event, or a retained placenta, your immediate thought should be, have I created a condition where anaerobes can establish? If the answer is yes, treat accordingly without waiting for culture confirmation. The clinical signs are your early warning system. The debridement is your most powerful treatment, and the antibiotic choice, penicillin or metronidazole, not aminoglycosides, follows directly from understanding the biology. Read the first case, think about it, we'll then go through it together. This presentation is classic for Clostridial myonecrosis, gas gangrene, most likely caused by Clostridium septicum or C. perfringens, introduced at the injection site. The spores can survive in the environment and on skin. Trauma from the injection creates a nidus of devitalized tissue with low oxygen tension. The bacteria germinate, produce alpha toxin and other cytotoxins that destroy muscle and vascular endothelium, further reducing oxygen tension and accelerating necrosis. The gas in tissue is CO2 and H2 from fermentation. This is a surgical and medical emergency. Aggressive debridement down to healthy bleeding tissue to remove the anaerobic environment, high-dose IV penicillin G, systemic support for toxemia, and anti-inflammatory therapy. Time is critical. This can be fatal within hours. Waiting for culture confirmation is not an option. Read the case, think about it, we'll then go through it together. Traumatic reticuloperitonitis involves perforation of the reticulum by a swallowed metallic foreign body, allowing GI contents, which are massively loaded with anaerobic organisms from the rumen and reticulum, to enter the peritoneal cavity. The peritoneum is normally sterile, well perfused, and aerobic, but the contaminating material rapidly creates localized areas of reduced oxygen tension, especially in fibrinous adhesions and walled-off abscesses. The organisms from rumen contents include Fusobacterium, Bacteroides, Peptostreptococcus, and various Clostridia. Empirical anaerobic coverage, penicillin G covers most gram-positive anaerobes and many gram-negatives. Metronidazole adds coverage for resistant gram-negative anaerobes like Bacteroides fragilis is clinically justified before culture. The clinical picture makes the anaerobic diagnosis. You treat the infection you know is there. Read the case, think about it, we'll then go through it together. First, a penicillin-sensitive result is useful. Fusobacterium necrophorum has historically shown good sensitivity to penicillin, and resistance is uncommon, so a susceptible result supports continuing that class. If oxytetracycline resistance is confirmed, stop using it and use the sensitive drug. But here's the critical systems point. Treatment failure in foot rot is often not primarily a resistance problem. It's an environmental and management problem. Fusobacterium foot rot requires predisposing factors, wet, contaminated environments, interdigital skin maceration, and often co-infection with Dichelobacter nodotus in sheep or concurrent digital dermatitis organism in cattle. If the herd is standing in slurry, antibiotic therapy will be repeatedly necessary and ultimately insufficient. Foot baths, dry lying areas, hoof trimming, and reducing stocking density address the predisposing factors. The antibiotic treats the individual, management prevents the next case.